Nursing care of patients with lower respiratory tract disorders. Bronchiostasis. In bronchiostasis, we have enlargement of the airways in the lung. Symptoms typically include a chronic cough and excessive production of mucus. These patients will appear with chronic infections, dilation of one or more large bronchi, and airway obstructions due to the excessive mucus production. Patients who typically present with this are those with cystic fibrosis, asthma, and tuberculosis. Signs and symptoms include shortness of breath, cough, large amounts of sputum, anorexia, recurrent infections, clubbing of the fingers, crackles, and wheezes. To diagnose, we look at the patient with x-rays, CT scans, we collect sputum cultures, and will do tests to determine the underlying cause. These patients are going to need antibiotics, mucolytics, expectorants, bronchodilators, chest PT, oxygen, and sometimes surgery. Pneumonia. This is caused by an acute lung infection. There is inflammation and alveolar damage. The alveoli are filled with exudate, and this reduces the area, the surface area that is required for gas exchange. So these patients are going to have an alteration in being able to perfuse tissue. It can be bacteria. If it is, it's usually caused by Streptococcus pneumoniae. It can also be caused by a virus, a fungus, aspiration, and that can be fatal, artificial ventilation, hypostasis, or chemicals. Prevention includes pneumonia vaccines for those who are at risk, flu vaccines, because the flu can actually lead to pneumonia, coughing and deep breathing, especially post-op, to prevent the lungs from collapsing, hand washing, and frequent mouth care, and continuous suctioning if the patient is on a ventilator. This helps prevent ventilator-associated pneumonia. Remember, we talked about this in the earlier slide about using that chlorhexidine. Signs and symptoms are going to be chest pain, fever. Sometimes these patients have a high heart rate, chills, cough, dyspnea. They could have yellow, rusty, or blood-tinged sputum, crackles, wells, and just a general tired and letharginess or malaise, not feeling well at all, and just feeling run down and like they're out of air, out of energy. In the elderly, especially if it's a new onset, you might see confusion, lethargy, fever, and shortness of breath. Complications of pneumonia are pleurisy, which is inflammation of the lining of the lungs and the chest, and that can lead to chest pain when you take a deep breath. Pleural effusion, which is that excessive fluid that can accumulate in the pleural cavity that's surrounding the lungs, and this can limit the patient's ability to breathe because they can't fully expand those lungs. Atelectasis, which is the collapsure or the closure of one or both lungs, and that can affect either all or part of the lung, but it does usually occur only on one side. And then spread of infection, and this is spread by droplet. Diagnosis for pneumonia is usually done with a chest x-ray, a sputum culture, and blood cultures. The patient's going to definitely receive antibiotics, PO or IV. If it's caused by a virus, they'll receive something called Zovirax, which is an antiviral medication. Or they may be given bronchodilators to open up or dilate the breathing passages and the bronchial smooth muscle. Remember, with bronchodilators, what the patient may be at risk for as far as side effects. So make sure you know that. Expectorants, these help increase bronchial secretions and make them easier to cough up mucus from the airways and the lungs. You should know that. We may have to give O2 support. And then fluids, which will help keep the secretions moist and make them easier to move. These patients are going to need an increase in fluid of up to 3,000 mLs a day. Now, make sure you check the patient's history before you give them all those fluids and be sure that they can tolerate that. If they have other disease processes like kidney or heart failure, obviously you would have to follow their fluid restrictions. TB. So TB, we look for an acid-fast bacilli implant on the bronchioles or the alveoli. And remember, we talked about this earlier, that it has to be a Mycobacterium acid-fast bacilli. AFB stands for acid-fast bacilli, and it's used to diagnose TB. A sputum specimen is obtained and tested for the AFB. If the sputum's negative, then it helps rule out that TB. There's some other tests that we can also do in combination with that test to diagnose TB, including a chest x-ray. So tubercules are actually formed. The bacillus spreads slowly and widely through the lungs, and it's going to cause the formation of those tubercules in the lungs. They're going to look like hard nodules, or sometimes they look like large cheese masses, and they break down the respiratory tissue and form cavities in the lungs. The immune system helps to keep it in check. So typically M. tuberculosis will remain dormant in the body, and then the immune system keeps it in check. And at that point, it's called latent tuberculosis. But when the immune system becomes compromised, like the patient gets an infection or something else happens to compromise that immune system, then the active disease will come awake and present itself with fever, weight loss, night sweats, a productive cough that may be with or without hemoptysis, and it won't respond to conventional antibiotic therapy. About 5 to 10% of people infected become ill with it. So the main thing to remember is that it usually stays latent, and then it can be activated with any sort of impaired immunity or immunocompromise. So who's at risk? The elderly, alcoholics, anybody living in crowded conditions, new immigrants, and those with HIV. Signs and symptoms again: cough, blood-tinged sputum, night sweats, anorexia, weight loss, low-grade fever, dyspnea, and chest pain are late signs. Diagnostic tests include the PPD, which is that Mantoux skin test, a chest x-ray, and sputum cultures. They also have the quantiferin TB Gold, which is a simple blood test that helps detect Mycobacterium tuberculosis. It's an interferon gamma release assay, and it's used as an alternative to the TB skin test. It's really specific and sensitive to TB, so it can strongly predict a true infection with the M. tuberculosis, but it doesn't have the ability to distinguish between the active and the latent disease, and it's extremely expensive, so that's why usually the PPD would be used first. So for a definitive diagnosis of TB, we're going to culture that Mycobacterium TB organism, and that comes from that sputum specimen. There are some other ways we can get it, like pus, cerebrospinal fluid, or some sort of biopsy tissue. And if that comes back as positive, then it would be considered a definitive diagnosis. Anything else would be considered probable or presumed, but the sputum test gives us a definitive diagnosis. Now, the TST or the Mantoux skin test can be used to test for M. tuberculosis infection. Additional tests are required to confirm the disease. A chest x-ray is used to detect abnormalities in the chest, and that can be used to rule out the possibility of pulmonary TB in a person who has a positive reaction with no symptoms. So for all patients, the initial M. tuberculosis isolate should be tested for drug resistance. For these patients, we're going to use a combination of drugs from anywhere from 6 to 24 months. The normal length of treatment is 6 to 9 months. And the drugs are INH, or ionazide, rifampin, streptomycin, and ethambutol. That's just some of them. There's a much bigger list, I'm sure, in your drug guide. Sometimes surgery can be done on these patients, but it's not very common. It's actually kind of rare. And this would be used to treat extensively drug-resistant TB, which is called XDR TB, or to treat complications of an infection in the lungs or another part of the body. It can help repair the lung damage, like serious bleeding, but you know, that's about the basis of what it really does. So if the patient has the active disease, they'll be in isolation. So these are some of the nursing diagnoses that a person with TB would be expected to have, and that's going to be the impaired gas exchange, ineffective airway clearance, ineffective breathing patterns, activity intolerance, and some things that go along with the impaired gas exchange, monitoring the lung sounds, shortness of breath, changes in the mental status, and the arterial blood gases. We have to think about positioning the patient appropriately using Fowler's position and the good lung down theory, providing oxygen and teaching breathing exercises, and always discouraging smoking. So some more for ineffective airway clearance. I'm not going to go through all of them, but you can basically look at them. Some are the same and some aren't. So with this, I left this one in here because this one talks about the sputum that's produced and all. So for that, you're going to have to give expectorants. We don't want that airway to get obstructed. Fluids, deep breathing, coughing, turning that patient, ambulating, suctioning them, and then ineffective breathing pattern. And this is mostly about teaching them how to use that different breathing techniques to conserve energy and to help them breathe when they need to do certain things, and positioning. And then activity intolerance. They're going to be fatigued, and so they're going to have to limit their activities, and there's some things that they can do to help limit their activities and also conserve energy. This is just some other diagnoses that we might see. Remember, this can also have some effects on the patient, so we need to make sure that our family's patient is aware of the risk for transmission and also for helping care for the patient. So to prevent the spread, we need clean, well-ventilated living areas. Patients who have active disease must be isolated. We'll follow PPE guidelines like the high efficiency filtration masks, negative pressure rooms, gowns, gloves, and goggles if you anticipate coming in contact with any of the sputum. So we also have some restrictive lung diseases such as asbestosis, sarcoidosis, and pulmonary fibrosis. And these diseases restrict lung expansion, meaning how well the lungs compliance or chest wall expansion is. So they restrict the lung expansion, and this causes a decrease in lung volume, an increase in the work of breathing, and inadequate ventilation or oxygenation. It's caused by reduced compliance, where the lungs' ability to stretch and expand is affected, or by limited chest wall expansion. Pleurisy is inflammation of the visceral and parietal pleurae, and this causes friction between the pleurae on inspiration, and it's usually secondary to pneumonia, tuberculosis, cancer, or a pulmonary embolism. So these patients will have extremely sharp pain on inspiration, shallow breathing, fever, elevated white blood cell counts, and a friction rub. So for these patients, we're going to do a chest x-ray, a CBC. We're going to look at the forced vital capacity and the forced expiration volume. And we get this ratio called the Tifano-Pinelli index. And it calculates this ratio to diagnose obstructive and restrictive lung disease. So it's looking really at how a person's ability to expand and contract those lungs is really working. So it's called the Tifano-Pinelli index, and it really represents the portion of a person's vital capacity that they are able to expire in the first second of forced expiration to the full vital capacity. And then also we'll do tests to help determine the cause. Therapeutic interventions include pain management and treating the underlying cause. For pleural effusion, now this is excess fluid between the visceral and parietal pleura. So the parietal pleura is the pleura that lines the inside of the chest wall, and it covers the surface of the lung. The pleural fluid is not reabsorbed, and this can cause the lung to collapse. There are two types of effusions that can occur. One is called a transudative, and the other is an exudative. And the transudative usually occurs in heart failure or liver or kidney disease, where fluid pressure is built up in the blood vessels and it begins to increase. And then pressure exerted by proteins like albumin can be decreased. And so, of course, we already talked about albumin and how it holds the fluid in the blood vessel, but because it's decreased, the fluid is now going to move from the blood vessel into the pleural space. And so this is called a transudative pleural effusion, and the most common cause is heart failure or liver failure. It becomes a systemic issue. Now, an exudative effusion is usually seen in pneumonia, tuberculosis, and cancer. And this is where we have too much protein-rich fluid in the cavity surrounding the lungs, and it can be caused by local tissue injury around the lungs. And this impairs the patient's ability to breathe because it limits the lungs' ability to expand. And again, common causes of this are going to be cancer, trauma, and infections like pneumonia and tuberculosis. So signs and symptoms are going to be shortness of breath or a sudden onset of shortness of breath, pain, cough, tachypnea, and diminished lung sounds. So for this, we may give analgesics. We're going to do a chest x-ray, a thoracentesis probably to remove the fluid or the air from the pleural space. We may have to insert a chest tube and then diagnostic test to determine the underlying cause. In pulmonary fibrosis, the lungs become scarred, thickened, stiff tissue, and they're damaged. The accumulation of the excess fibrous connective tissue leads to thickening of the walls and reduces the oxygen supply in the blood. This causes injury to the alveoli, scarring, and fibrosis, and impaired gas exchange. So when the patient tries to breathe, it's like sucking out of a straw. This can be caused by a multitude of things. It can be heredited, viruses, environmental occupational exposure, immune dysfunctions, idiopathic, some autoimmune diseases like rheumatoid arthritis, and the patient progressively just becomes shorter and shorter of breath. So these patients are going to have progressive dyspnea, crackles in the lungs, a chronic cough, fatigue, and clubbing. Diagnosis can be made with chest x-ray, a CT scan, or bronchoscopy, which is going to help examine the lower airway, including the larynx, the trach, the bronchi, and the bronchioles. And it can also help examine the surface of the airways for abnormalities that might be associated with different lung diseases. A lung biopsy may be done, or an ANA titer. A positive ANA titer would indicate the presence of an autoimmune disease. So for these patients, we're going to treat them with glucocorticoids. Hopefully that will stop the inflammation that is causing the tissue damage and slow it down. So we might give them prednisone. The doctor might give a second drug, those immune suppressants, azathioprine or cyclophosphamide, to try to slow the progression of the lung scarring. And then we're going to teach smoking cessation, teach the patient about oxygen use and provide oxygen support, teach them about flu and pneumonia vaccines, refer them for pulmonary rehab and a possible lung transplant. In atelectasis, we have a collapse of the alveoli, or the lung tissue, and it can affect part or all of one lung. This is the tiny sacs in your lungs called alveoli, and they don't inflate. You have hypoventilation. This could be caused by things like pneumonia, where the sacs are filled with fluid, or other causes, as you'll see on the next page. So in atelectasis, we have a collapse or an airless condition of the alveoli. Airless condition might be where there's fluid inside there, caused by hypoventilation or obstruction to the airways or compression. Causes are bronchial obstructions by secretions due to an impaired cough mechanism or a condition that restricts normal lung expansion on inspiration. Post-op patients are at high risk. Symptoms are insidious, meaning they might be subtle or not recognized right away, and they can include cough, sputum production, and low-grade fever. Additional symptoms would be respiratory distress, anxiety, and hypoxia, restlessness, decreased level of consciousness can occur if large areas of the lungs are affected. These patients are going to have fine crackles, diminished breath sounds, and shortness of breath. So we need them to cough, deep breathe, use the incentive spirometer, turn every 2 hours or frequently, and ambulate. And then nursing diagnosis is impaired gas exchange, ineffective breathing, acute pain. Obstructive disorders such as airway obstruction causes difficulty in exhalation for these patients. This might be like COPD or emphysema. So these patients have a combination of chronic bronchitis, emphysema, asthma, and they have a chronic issue with airflow limitation, meaning that they're not able to get all of the air out, and that causes that hyperinflation of the lungs we talked about. They have increased mucus production, inflamed mucous membranes, constricted bronchial pathways, and then distended respiratory bronchial. And so it's just a combination of things there together that are prohibiting those lungs from working correctly. They're going to have chronic bronchitis, chronic inflammations. They may have low-grade infections. They're going to have hypertrophied mucus glands in the bronchi because they're constantly producing mucus, so it's making those glands grow. Anytime something works over time, it can make it, get bigger. They're usually diagnosed with this after they've been ill for at least 3 months of the year for 2 consecutive years. Emphysema With this, the patient's going to have destruction of the alveolar walls. They're going to lose that elastic recoil. So when they go to breathe out at the end of exhalation, the coiling process doesn't work and it fails, and it's non-compliant, so it can't stretch, expand, and then draw back like it's supposed to. So it doesn't stretch or work like it's supposed to. It collapses and it retains air there in the lungs still. So some of that air is carbon dioxide because that's what we're trying to exhale out. So not only are they going to retain extra carbon dioxide there, but they're not able to completely exhale, and then that air remains in the lungs and can hyperinflate that chest or make it have that barrel-like appearance. They're going to have damage to the pulmonary capillaries, the air trapping that we just talked about, and therefore that's going to all lead to an impairment in the ability to exchange gas. So there's a couple different types of emphysema. You just, need to have the basic concept of what it is and what causes it and what kind of treatment the patient is going to need to treat it. So again, we have that air trapping in chronic airflow limitation. Air trapping is caused from excessive mucus and from the decreased elastic recoil and the narrowed airways. So in the top picture, mucus is built up in the lungs there. It's thick. You can see it in the airway or the bronchioles, and so the more mucus there is there blocking that airway, the less amount of air is able to get out. And then on the bottom, you can see that the alveoli are not contracting and expanding the way they should. The airway isn't either, and it collapses, and so that traps air in there. Etiology for COPD: smoking, passive smoke exposure, secondhand smoke, pollutants. They could have a familial predisposition, and they could also have A1AT deficiency, especially if they have emphysema. And this is called the alpha-1 antitrypsin deficiency. It's a genetic disorder, and it can result in lung disease or liver disease. So with these patients, they might have lung problems as early as 20 years old, and that can result in shortness of breath, wheezing, and increased risk for lung infections. Complications may include COPD. So this graph shows the effects of smoking and different risk factors in how the forced expiration volume can be affected based on the age of the patient. So it decreases over time, and if you stop smoking at an earlier age, you can actually regain some of that use back or not lose as much of it. So the main thing is to prevent or stop the patient from smoking. Signs and symptoms: cough, sputum production, shortness of breath, prolonged expiration, barrel chest because of that trapped air, and activity intolerance. They're going to have symptoms of chronic bronchitis, wheezing, crackles, a chronic cough, shortness of breath, a thick, tenacious sputum. They may have increased susceptibility to infection, and they're going to produce mucus plugs. For emphysema, they're going to have diminished breath sounds, shortness of breath, a progressive activity intolerance. So as time goes on, there's going to be more and more that they can't do because they're going to become shorter and shorter of breath. With COPD, because of the chronic high blood pressure in the lungs, or what we call pulmonary hypertension, this patient can develop a condition called cor pulmonale, and this is a combination of right-sided heart failure and this pulmonary high blood pressure. The patient can have weight loss, a pneumothorax, which is that abnormal collection of air in the pleural space between the lung and chest wall, and ultimately respiratory failure due to the body's inability to properly exchange gas. So their oxygen and carbon dioxide levels are both going to be off, or at least one or the two. And when that O2 sat drops, that's going to be called hypoxemia. And when that carbon dioxide level rises, that's going to be called hypercapnia. Diagnostically, we can evaluate these patients with chest x-rays, CT scans, ABGs, CBCs, spirometry, and sputum analysis. Again, therapeutic interventions are going to be stop smoking, O2, 1 to 2 liters per minute, supportive care, pulmonary rehab, surgery, medications, bronchodilators, corticosteroids, expectorants, nebulizer mist treatments, and MDI inhalers. Also, they might have a small implantable mechanical device. This is a one-way valve that can be implanted into the airway in the pulmonary system to help treat certain lung conditions, mechanical ventilation, and end-of-life planning. So these patients might benefit from pulmonary rehab, and it just depends on the patient and whether or not they're going to be compliant with that. Asthma. Asthma is a disease that inflames and narrows the airways. It causes inflammation of the bronchial pathways, spasm of the bronchial smooth muscles, and air trapping, and it's sometimes reversible. It also causes airway remodeling because it's a chronic disease that leads to permanent lung damage. Permanent changes in the airway are caused from these repeated asthma events that cause recurring inflammation of the bronchi. This can ultimately lead to airway fibrosis or scarring and permanent narrowing of the airways, known as remodeling. Asthma can be inherited, or it can be caused by airborne allergies that trigger it, pollution, or smoking. Other triggers include infection, sinusitis, stress, GERD, sometimes the environment, the cold air can trigger it, and sports. Signs and symptoms are dyspnea, wheezing, cough, sputum. These patients will go into respiratory distress and use their accessory muscles to breathe with. So you're going to see that nasal flaring, the retractions in the sternocleidomastoid muscles and in the rib area. And it can be worse at night. Complications of asthma are status asthmaticus, which is a severe sustained asthma attack with worsening hypoxemia, which progresses to respiratory alkalosis, then respiratory acidosis, and eventually it can go into a coma and the person can die. We are going to get a full history and physical on these patients. We're going to use something called spirometry, which is the most common of the pulmonary function tests, and we're going to measure lung function, especially the amount, the volume and or speed flow of air that can be inhaled and exhaled. This is helpful in assessing conditions such as asthma and some other issues like pulmonary fibrosis, cystic fibrosis, and COPD. We're also going to check their ABGs and possibly do some allergy skin testing. Therapeutic interventions are to monitor the patient with the peak flow meter, avoid triggers or teach them to avoid triggers, and teach them to avoid smoking. Adrenergic beta-2 bronchodilators such as albuterol are used as first-line treatment for asthma, especially acute asthma attacks. They dilate the bronchi by using a direct action on the beta-2 receptors on the bronchial smooth muscle to relax the muscles. Leukotriene inhibitors such as Accolade and Singular are generally used for long-term maintenance. They're not used for acute asthma attacks. They do help reduce inflammation in the airways and inhibit leukotriene production. Leukotriene causes nasal passages to swell and can make excess mucus. It's also responsible for tightening the airways during an asthma attack, making it harder for the patient to breathe. Rarely used is a theophylline bronchodilator. Sometimes this is because of tachycardia. It helps relax the muscles in the lung and the chest and makes the lungs less sensitive to allergens and other causes of bronchospasms. They're used to treat symptoms such as wheezing or shortness of breath caused by asthma, bronchitis, emphysema, and other breathing problems. Remember, when we're talking about beta drugs, beta 1 is for the heart and beta 2 is for the lungs. We have one heart and two lungs. Corticosteroids help decrease inflammation. They can be given IV, PO, or inhaled. Mast cell inhibitors are often used for exercise-induced asthma. They stop the release of histamine and related mediators. They're used to prevent or control certain allergic disorders. They can block mast cell degranulation to help stabilize the cell to keep it from breaking down and releasing that histamine. Antihistamines can also be given as well as oxygen as needed. Cystic fibrosis is an exocrine gland disorder. The patient is going to have thick, tenacious secretions. Their pancreatic enzymes will be blocked, and these patients inherit the trait for this disease. So signs and symptoms are thick, tenacious sputum, frequent respiratory infections, finger clubbing, malabsorption because of the lack of the pancreatic enzymes, fatty, foul-smelling stools, and death from antibiotic-resistant infections. Back in the day, babies were diagnosed with cystic fibrosis using the Kiss Your Baby campaign. The sponsors of the campaign said that if your baby tasted salty when kissed, the child should be checked for cystic fibrosis. The sweat chloride test is a common and simple test used to evaluate patients who are suspected of having cystic fibrosis. Patients with cystic fibrosis will produce larger quantities of sweat chloride than normal people. Therapeutic interventions for these patients are hydration to help with those thick secretions, inhaled mucolytic medications, bronchodilators and corticosteroids, expectorants, chest PT, and antibiotics. So in these patients, we need to prevent infections. They'll be given pancreatic enzyme replacement with Pancrease and Biocase. They also might be given ibuprofen because ibuprofen has the potential to slow down the lung deterioration. It decreases inflammation. The inflammation that these patients chronically experience can lead to tissue damage in the lungs, and by giving the ibuprofen, we may be able to slow down the progression of the disease. We do have to be cautious in using the ibuprofen because of unwanted side effects. These patients may also be a candidate for a lung transplant. Pulmonary embolism is a blood clot in the pulmonary artery. It generally travels there from another place, so maybe it was in the leg and it dislodged and it has now traveled up to the pulmonary artery. A ventilation perfusion mismatch is a condition in which one or more areas of the lungs receive oxygen but not blood flow. So these patients will receive blood flow but no oxygen due to some disease process or disorder. A lung infarction is death of one or more section of the lung tissue due to deprivation of an adequate lung supply. So this is showing you the occlusion with the pulmonary embolism, and that could lead to an infarction because once the tissue there, if it gets totally occluded, it's going to die. The DVT is the most common cause of pulmonary embolism. Fat emboli can also cause them, and this can occur with a compound fracture or trauma. Amniotic fluid emboli can also occur during labor and delivery. Things that might help us prevent a pulmonary embolism would be things like regular ambulation, prompt treatment of a DVT, and anticoagulants in any high-risk patients like warfarin, enoxaparin, or heparin. Signs and symptoms of a PE are sudden onset of shortness of breath, tachycardia, tachypnea, cough, crackles, and hemoptysis. This is where you cough and blood comes up. Diagnosis can be done with a spiral CT scan, a lung scan, an angiogram, which is used to visualize the inside of the lumen of the blood vessel or organs of the body, a D-dimer, and this is a blood test that measures a substance that's released when the blood clot breaks up called fibrin, and this is ordered with other lab tests and imaging scans to help check for blood clotting problems. Other interventions for this patient would include thrombolytics to break up the clot, like streptokinase, heparin, which is an anticoagulant, warfarin, which is an anticoagulant. Heparin is given IV, and warfarin can be given orally and not IV. These require blood monitoring, so PTT for heparin and a PT or a PT-INR for warfarin. Administration of oxygen, and an embolectomy as a last resort. This is an emergency surgical removal of the emboli that's blocking the blood circulation or the blood flow. This is an emergency procedure and would definitely be used as a last resort. We may also do a filter in the jugular or femoral vein, and this could help with any episodes of recurrent PE to try to catch the clot. So nursing diagnosis is impaired gas exchange and risk for injury related to that anticoagulant use. Pulmonary arterial hypertension. This is elevated pressure that occurs in the pulmonary arteries, and it can lead to right ventricular failure. We talked about this a little bit when we talked about the cor pulmonale, and that can occur in a patient with COPD. The etiology is unknown, and it can be secondary to coronary artery disease or valve pressure. Signs and symptoms are dyspnea, fatigue, crackles, cyanosis, and tachypnea. Diagnostic tests are going to be ABGs, a cardiac cath, possible EKG, or additional tests needed to find out the cause. Therapeutic interventions are going to include a low-sodium diet, diuretics, vasodilators, oxygen, and warfarin. Nursing care for these patients would include monitoring the respiratory status, bed rest, repositioning as needed, and providing comfort measures. Pneumothorax. This is air in the intrapleural space, and it can cause complete or partial collapse of the lung. In the intrapleural space, the pressure within the pleural cavity is normally slightly less than the atmospheric pressure, or referred to as negative pressure. When that pleural cavity is damaged or ruptured, the intrapleural pressure becomes equal or exceeds the atmospheric pressure, and a pneumothorax may ensue. There are three different types of pneumothorax: a spontaneous pneumothorax, a traumatic pneumothorax, and a tension pneumothorax. A spontaneous pneumothorax is when part of your lung collapses, and it can happen if air collects in the pleural space. The trapped air in the pleural space then prevents your lung from filling properly with air, and it collapses. A traumatic pneumothorax is caused by an injury that tears the lung and allows air to enter that pleural space. The air is then trapped between the lung and your chest wall, and the air trapped in the pleural space prevents your lung from filling with air, and that causes it to collapse. A tension pneumothorax is a condition in which air becomes trapped in the pleural space. This is usually caused by trauma to the lung or a punctured lung. The patient continues to breathe and pulls air into the injured lungs, but the air escapes into the chest cavity. This is a life-threatening situation. These patients are going to present with shallow, rapid respirations, asymmetrical chest expansion, dyspnea, chest pain, and they will probably have absent breath sounds over the affected area. The tension pneumothorax signs and symptoms include tracheal deviation, where the trach actually shifts, bradycardia, cyanosis, shock, and death if left untreated. History and physical exam will be part of your diagnostic testing, along with an ultrasound at the bedside, a chest x-ray, ABG monitoring, and SpO2 monitoring. So for these patients, we will monitor ABGs and respiratory status. Connect the chest tube to the water cell drainage. We will do a pleurodesis for recurrent collapse. Remember that the pleurodesis is performed to prevent recurrence of the pneumothorax or recurrent pleural effusion. It uses medicine to adhere the lung to the chest wall to seal up the space between the outer lining of the lung and the chest wall, which prevents fluid or air from continually building up around those lungs. This can be done chemically or surgically, and it involves the adhesion of the two pleurae. For these patients, we're going to monitor respiratory status, monitor chest tube drainage, and report any changes right away. Rib fractures. These can be caused by trauma, cough, or CPR. We need to help these patients control pain. We need to encourage coughing and deep breathing and promote adequate ventilation. Flail chest is a life-threatening condition that occurs when a segment of the rib cage breaks due to trauma and becomes detached from the rest of the chest wall. It involves multiple rib fractures. The rib cage is not able to maintain the bellows action, so part of the chest wall moves independently. The chest cannot expand properly and cannot draw air into the lungs. Care is to provide mechanical ventilation and monitor the patient's ABGs. These patients are going to have impaired gas exchange, ineffective breathing patterns, and acute pain. In acute respiratory failure, we have hypoventilation. The patient is unable to maintain their ABGs. This can be caused by any impairment in oxygenation or ventilation in which the arterial oxygen tension falls below 60 mm per Hg, or the carbon dioxide tension rises above 50 per mmHg, and the pH drops below 7.35. The patient may have COPD, a history of aspiration, or neurological disease. Their ABGs will become worse and worse, and they'll have increasing dyspnea, restlessness, confusion, which will result in lethargy, coma, and death. ABGs, the PaO2 is less than 60 and the PCO2 is greater than 50. We'll need testing to determine the cause. These patients are going to need oxygen support, bronchodilators. We'll have to try to correct any underlying causes, possible intubation and ventilation, and we need to check their advance directive. Acute respiratory distress syndrome, or ARDS. This is caused by alveolo-capillary membrane damage. The alveolo-capillary membrane is a thin layer of tissue that helps the exchange of gases between the alveoli and the blood into the pulmonary capillaries. The pulmonary gas exchange occurs across this membrane. All disorders causing ARDS cause massive pulmonary inflammation that injures the alveolo-capillary membrane and produces severe pulmonary edema, shunting, and hypoxemia. So with these patients, you'll see pulmonary edema, alveolar collapse. The lungs will become stiff and non-compliant, and they might begin to hemorrhage. Causes of this can be acute lung injuries, sepsis, shock, or aspiration, and it's not usually seen in patients who just have chronic respiratory disease. These patients will present with shortness of breath, elevated respirations, fine crackles, respiratory acidosis, restlessness, confusion, and the death rate is 45 to 50%. Diagnostic testing composed of ABGs, chest x-ray, EKGs, and other tests to determine the cause. Therapeutic interventions include oxygen, intubation, mechanical ventilation. We have to treat the underlying causes and provide supportive care. Several nursing diagnoses for these patients: impaired gas exchange, ineffective airway clearance, activity intolerance. Lung cancer. There's multiple kinds. We have small lung cell cancer, large cell carcinoma, adenocarcinoma, and squamous cell carcinoma. Causes: smoking. Smokers are 13 times more likely to develop cancer as a non-smoker. Environmental tobacco smoke or secondhand smoke. Other carcinogens such as asbestos, arsenic, and pollution. So usually there's no signs until it's late. Then the patient gets a productive cough, starts to present with recurrent infections, dyspnea. They may have some hemoptysis, some anorexia and weight loss, pain, wheezing, or stridor. Remember, stridor is that obstruction in the airway, and it can sometimes sound like a crowing sound. Complications are pleural effusions, superior vena cava syndrome. You should know this from pregnancy, where there's compression put on the superior vena cava, so it decreases perfusion to specific areas of the body. Ectopic hormone secretion, such as SI-ADH. So these patients are going to have syndrome of SI-ADH, possibly. Too much ACTH, leading to Cushing's syndrome, or hypercalcemia from too much parathyroid hormone stimulating within the blood. They may also experience atelectasis and metastasis. Diagnostic testing will be chest x-rays, CT scans, sputum analysis, biopsies, and additional tests to see if metastasis has occurred. This is a picture of a cell of lung cancer. So therapeutic interventions will be done. They'll stage the tumor using the tumor staging system, chemotherapy, and possibly palliative care, and radiation in palliative care. If they go on to hospice, then of course those treatments would stop. But as long as they're on palliative care, depending on the stage, they would be still receiving chemo or radiation. So these are some examples of lung surgical removals, and there's different types. The top picture on the right, on the left, shows a wedge resection, and that's where just a piece is taken out. Then they have a segmental resection in figure B, and then C shows an actual lobectomy where they took out a whole section, and then a pneumonectomy where they have removed the entire lung. So for lung cancer, we have impaired gas exchange, ineffective airway clearance, pain, anticipatory grieving. So the pneumonectomy is the surgical procedure to remove a lung. The lobectomy is removal of just one lobe of the lung, and it's specifically referred to as a lobectomy. A resection is where we remove a segment of the lung as a wedge resection or a segmentectomy. Video-assisted thoracic surgery is a minimally invasive surgical procedure that is used to access the chest cavity and operate on the lung, the mediastinum, and the pleura, and it helps treat conditions such as cancer, pneumothoraxes, infection, cysts, and other thoracic disorders. The patient may also be a candidate for a lung transplant. Pre-op care, we need to monitor respiratory status, teach the patient any routine pre-op teaching, what to expect. They'll probably be admitted to SICU, and also the family should be included in the teaching. Post-op care, these patients are going to be in the intensive care setting. We need to monitor their vital signs closely, their SpO2, ABGs. We'll be following the hemodynamic parameters using probably a ventilator and chest tubes and listening to different lung sounds. So once again, ineffective airway clearance, impaired gas exchange, acute pain, impaired mobility, risk for infection.